Thank you for tuning in to watch Counting What We Care About, Data and Indicators in Creative Health Strategies. This event is brought to you by our South West Creative Health Associate, Penny Calvert. To access other event recordings hosted by our regional team, please visit the NCCH YouTube channel and select our regional playlist. Now, without any further ado, let's pass over to Penny.
I'm just doing the quick welcomes, and then we're going to go into some mini sort of case study delivery by Jayne and Hannah and Michael. We have a break in the middle with a little brain teaser in the style of 8 out of 10s Cats does countdown, a little teaser to keep your brains going while you stretch your legs halfway through. And then breakout sessions. There is a recording happening, and that will continue until the breakout sessions start. We will be sharing the recording after the webinar to anyone who signed up but couldn't make it to today's session, and also on future NHS. During the discussions that are going on, I'll be adding some links into the chat so that you can follow up any particular websites and things that we highlight. We are broaching the subject of data today and counting what matters. We're going to look at that from several different perspectives. And underneath all of it, we're thinking about the Creative Health Toolkit, because this is the first in the series looking at creative health strategy building. And because at the moment there is no one perfect way to do that, there are various ways to go about building a kind of formal, collaborative way of working at system level. And so there's going to be multiple routes to it. So today we're going to give you a few little tasters. Underneath that, we're thinking of the Creative Health Toolkit. I will put the link in the chat shortly. But the toolkit talks about leadership and strategy and governance, and the importance of facilitating connection and establishing the resources that shape and deliver, and that underneath all of that is the data that helps us make decisions based on real information. And knowing what matters most and what to measure are not always easy to do. But we're going to start by listening to Jayne introduce a little bit from Cornwall, and the understanding the burden of what it takes to prove the work that's happening on the ground. Then Hannah will give us her presentation that describes the way that Gloucestershire works and the really connected and powerful way that they're using data. We'll have a little brain teaser from Michael, and then Michael will talk to us about taking a different view of public health and looking at the bigger picture and what you might measure in terms of. I've got tongue-tied. Brilliant. I'll stop talking. I'm going to hand over to Jayne before I burble nonsense. So Jayne, if you'd like to give us an introduction to Cornwall. Any questions, please pop them in the chat. I'll keep an eye.
Great, thanks, Penny. So welcome all. So for purposes of this little next few minutes, I'm going to take my NCCH hat off and I'm going to put on my Artswell hat. So I am also the founder and director of Artswell, which is a small social enterprise based in Cornwall that advocates for creative health and the role of arts, culture and creativity in improving health and well-being. And I just thought, I think we thought it might be useful just to share with you what it's like, and some of you will experience this, what it's like from the perspective of an organisation that's asked to collect data for various reasons. And I'm going to give you just two examples. One with which we haven't yet started to collect the data, but we're about to, and one where we were collecting information last year. So the first one is the one that's most recent. So Artswell secured funding from the Levelling Up Fund in Cornwall to work in community health and wellbeing hubs down here. So we'll be working in 9 hubs over the next 6 to 7, 8 months, something like that. And it's not insubstantial. It's we've got about £56,000 from the Levelling Up funding to do that work. And I just thought I'd share with you the data that we are going to be asked to collect. And obviously we've had to sign up to this as part of our contract. And just for you to be, as you're hearing me speak about what we're being asked to collect, just having a think about whether that has any resonances with you and how useful it is or otherwise. So we're being asked to collect the numbers of people attending our sessions and for how many hours. The number of repeat attenders as well. So we've got those figures in. The number of volunteers. So part of our project is about recruiting volunteers, and the number of hours that they give to us. We're being asked to collect the WEMWEBS scores, one of Michael's favourites, I know. WEMWEBS, the Warwick Edinburgh Mental Wellbeing Scale scores for participants in our projects. We're also being asked for demographic data, so age, gender, those sorts of issues, and the first part of people's postcode, because this funding is specific to certain areas in Cornwall, so they want to make sure that we are addressing the needs of people in those areas. And also we're providing some training, so it's also the number of hours of training that we provide. So it doesn't sound too bad, but we're working across 9 sites. We're working with artists who are delivering those programmes, and we're going to be dependent on those artists to collect that information for us. It's quite onerous, I think, and we are spending approximately 10% of that budget that we've got for this money on a person to collect and put together all of that data to feed back to the funder. Oh, the other thing we've also got to collect is exactly how we spend the money on what, and we have to show evidence of defrayal. So again, some of you will have been in that position where you not only do you show how you've spent the money, you have to show that the money has exited your bank account. So you have to keep all your various records to do with that. So, and we have to keep copies of invoices and all of that. So we are taking somebody on to just do that sort of monitoring role. And for me, that does feel like monitoring, but it is quite a lot of work. And within all of that, I think it's not really capturing very much of what we would like to capture in terms of understanding the impact of the work that we're doing. So we will obviously be looking at other mechanisms for collecting data and information as part of that project. And this is where I come to the second example, which was some work we did going back 18 months, 2 years maybe now, with a grant from the public health team, also in Cornwall Council. These are both in Cornwall Council, so just different funding streams. We had a grant from public health, the public health team, which was some post-COVID funding that they took a very enlightened approach to allocating, really. So people were invited, both BCSE organisations and local authority were invited to submit applications for that funding. We got about £100,000 for that, for work over a period of 9 to 12 months. And they had a very different approach. So we didn't have any detailed KPIs or figures or anything like that. What they said to us from public health was, they said, well, we know that this works. We understand that the evidence is out there, the research is out there. We know that this works. We trust you as an organisation to do the best that you can to deliver good work. What we will have are some regular learning meetings throughout the project. And those learning meetings really focused around questions which were, how's it going and how do you know how it's going? And what changes are you making, if any, to the programme, and why? And what are you learning through the programme? So it was a different style of looking at impact, really. We did produce a final report which had in it case studies, it had in it the learning. We also chose to do a social return on investment analysis of the project, which meant that we did need to collect numbers. So we were still collecting numbers of participants, and we were looking at certain measures for wellbeing to put into the social value engine. So, but it just felt very different. It felt like a much more partnership approach to working. It felt like we were being trusted as grown-ups to do a good job, and it meant that we could really focus on what were we trying to achieve through this funding and through this project. So I guess, what I'm reflecting on is the challenge really for a small organisation like ours is that, different funders will want different things, and I understand that, but it is a challenge for organisations to build their own evaluation tools and build some consistency in those evaluation tools. It's something that we would really like to do, to be able to come up with something that we use consistently to measure what we're doing. I'm interested to hear from Michael later on. But it's just a thought. So those, I think, are sort of two different ends of the spectrum in terms of data and indicators. The first one, I think, feels very much like monitoring rather than anything that we might be able to use in sort of more detailed evaluation. I completely understand why it's necessary. The second was much more around how are we learning from this project? How do we know that we're doing the best that we can with it? And there may be something else that we want to look at as well. So yeah, it's been interesting to have those conversations. And I feel that we're still, and again, I'm sure many of you reflect this, we're still in a position where sometimes we're having to prove that the work that we're doing in creative health is having an impact. And sometimes we're just being asked to prove that we're doing a good job, and they're very different things. And so, and they require quite different types of data, I think. I think that was all I was going to say, Penny. I haven't taken up very much time at all, so I'll hand back to you.
And she's on mute, and now she's off mute. Perfect. Are we even doing a webinar if someone doesn't have a technical hitch? So Jayne, while I've got you there, I probably should have shown this in the beginning, but I just wanted to see, when we were planning this webinar, I was trying to understand how could we illustrate what it is we're trying to understand what goes on. So if we're looking at this diagram, and we know that over here on the left, you've got creative health activity happening, and that usually, sometimes, perhaps data travels from that activity into a system. That might be that it's commissioned directly by the ICB and it's going there. It might be that it's activity that's been funded through the VCSE, for example, some health inequalities money. So somebody's reporting data to someone. But do we know that that goes anywhere other than to the someone? Does it make any difference? So Jayne, just thinking about the two different versions of data collection, which one does this diagram feel useful? Does it feel like it's the same in both situations, or are you just sending digits off to a random inbox?
It's probably too early to say with regard to the levelling up funding. If I'm honest around that, we need to see where that data goes. I think with the work that we did with public health, the other part of that work was also we were asked to work to share our learning with other organisations who'd also had funding from that same source, with a view, I think, to looking at that bit about system changes. It wasn't necessarily about reducing barriers there. It was about how can we collaborate more effectively? How can we learn from each other? How can organisations that are often supporting the same individuals but in different ways, how can we do that more effectively? So I think that definitely did, it did go somewhere, because we had those conversations, and it went into other people's learning as well. In terms of population health changes, I think that's the real challenge, isn't it? That's what we're trying to achieve through this work that we're doing. But how we measure that and whom we report it to is more of a challenge. As I said, we weren't asked as part of that particular project to collect anything like health outcomes data, because there was a recognition that if we did this work, we could anticipate that health and well-being of people would improve because of the evidence that we'd already got. But we weren't really able to evidence that direct. We were with some groups, but not with all of the groups. We weren't able to evidence that directly. But I think that is the big challenge.
Yeah, so by no means smooth, and definitely big gaps in different places. Okay. Hannah, how are you doing? Are you ready to give us a lovely summary of how Gloucestershire works with data and the impact that it's making there?
Yeah, thank you. I'm just doing that great thing now where I'm going to share my screen, and so it goes a little bit quiet and everything. I introduced myself earlier, but just in case people have come since then, I'm Hannah Gorf. I'm a senior programme manager for NHS Gloucestershire, and I've just seen that a colleague of mine has joined, Amy, who's from the University of Gloucestershire, because we're working on an arts, health and wellbeing centre together. So if anyone ever wants to hear about that, then have a chat. Yeah, I was going to talk about our data dashboard, but it is just our data dashboard is just one part of our bigger strategic picture around capturing value around creative health in Gloucestershire. And I think it's really important that we constantly ask ourselves, whose value, like who are we talking about, like value to who? How do you identify what to capture? So basically, by building on what Jayne just said. So in Gloucestershire, we have our Gloucestershire Creative Health Consortium, award-winning Creative Health Consortium. And it was a real trailblazer at the time of thinking and implementing different ways to measure impact with arts organisations. And one of the aims of the consortium was really around increasing the likelihood of high quality outcomes for individuals and communities. And they were already demonstrating really great impact through qualitative measures. And we just wanted to think about a more holistic approach that included what we like to call like the stats behind the stories. So there's a lot of slides, by the way, but I'm not going to talk, I'm not going to say what's on the slide. That's more about after this. You're all welcome to have the slides, and then you can potentially use any of the information. And to think about just to build on what Jayne was just talking about, you know, how it can feel to be asked for all this data. And this I feel like this definitely sort of was all of our feeling at the beginning of when we said, let's create a data dashboard for creative health. And we had to really think about why we would do that and what we would do with the information, because it does take time. And like Jayne said, you know, that time is precious and capacity is precious. And you have to always think about, you know, is it worth 10% of, like, you know, and getting someone, recruiting someone, you have to make it really worthwhile. So you have to be really thinking about what is our shared vision, goals, ambitions, and then thinking about who's going to be capturing that data, and do they understand why they're capturing the data, because that all leads into better data quality. And at the beginning, I would say we started capturing data to prove that it worked. And then we wanted to also capture learning about the process, you know, so not just the outcomes, but learning really about what works in the whole process. And now we're capturing data for improving, what we call in the NHS continuous improvement. So we've moved from capturing information from proving to improving. That's sort of been our journey. And our main ultimate aim in Gloucestershire is changing the narrative from arts and health being a nice to have to a need to have. And so that's almost our mantra whenever we think about getting together and talking about capturing data. Is it going to help change the narrative? And so every time we capture data, who needs to see this data and how do we need to communicate it to people? And we change that based on who we're talking to. And then we agreed all of it's a bit of a theory of change in a way, a little bit of this aims and objectives, but this is our co-designed, almost like aims and objectives through capturing data and evaluation. I won't read it, you can all read it after. But at the heart of everything, around everything we do, including data, capturing data, is our co-production approach in Gloucestershire. So you have to measure what you value, otherwise you'll end up valuing what you measure. And that's it's another like mantra in Gloucestershire of ours. And so, but also our director is a health economist. So we have to be really pragmatic, you know, about who we capturing evidence for and why. And it does include our director. And so, but what we do is we have this co-production approach that runs throughout. So that includes clinicians, the arts organisations, people with lived experience, and relevant commissioners, because it's no point just me being in the room as a commissioner. You know, I need to make sure the mental health commissioner's in the room as well, because if we really want to embed this, then the mental health commissioner, if it's a mental health project, then the mental health commissioner has to be brought into this as well. But the important thing is that we all agree what we think is important, including those people with lived experience. You know, so if we all agree why we're here and what we value collectively, then we will all agree what we need to capture in the data. And that is just a golden thread throughout everything. And then it's about making sure that we go back to the co-production group with the data that we collect to say, this is what we've collected. Does this look right? What do we need to do next? But I'll come on to a bit more of that detail later. And so we had the Ideas Alliance come and help us think a bit strategically a couple of years ago about our creative health programme, and they looked at some of the data that we collected. And we learned more. They went and talked to clinicians and commissioners and arts organisations and people that had participated in our programmes. And we really learned more about capturing hearts, hence some of these a quote, but also, so this is, by the way, from a consultant that says the single most effective way of getting things changed is getting someone to come along and tell their story. And then the minds. So what we do is we're capturing hearts and minds constantly with our data. And so I thought we could look a little bit at the data that we collect. So we've got two main approaches in Gloucestershire, which is we adapted the Public Health England's Arts and Health Evaluation Framework. And so we use that, and then we've got our data dashboard. And again, thinking about what Jayne just said, what we ask now is that commissioners use that evaluation template so that if anyone's doing any sort of creative health, cultural activity, and another commissioner wants to commission that, that's fine. But we say, can we just use this as a blanket template so that everyone knows what they're doing and what they're collecting, just to add to what Jayne said. And I'm not going to go into this detail, but I just wanted to have these slides for people to look at after this webinar about the technical, how we got to the data dashboard that I'm about to show you, because it was a lot of hard work. And we don't take it lightly, and we thank everyone that was involved in setting it up, because it did take a lot of partnership working. And these are some of the ingredients that we needed to ensure that we got to where we are now. And again, I'm not going to go through them because you can read them after about what we did. But now these are the types of things that our data dashboard can tell us. So it starts with our referrals are increasing, and I do believe a lot of that is because we're able to now use both qualitative and quantitative information to look at who's utilising our programmes, who's not utilising our programmes, who's referring to the programmes, who's not referring to the programmes, and really start to get the devil in the detail, you know, of like what's happening on the ground and what we need to do collectively to make it even better. So these are the types of things that we can gather, and this is because in the main we collect NHS number. So a big part of that technical piece, the how did we do it, the technical bit, is because the Creative Health Consortium members collect NHS number, and the NHS don't take that lightly, because your NHS number holds a lot of sensitive information and confidential information. And so those partner organisations in the Creative Health Consortium have to do a lot around data security to ensure that they can collect NHS number. But what it means is it opens up a whole world of information, like data information. And so we can really dig deep. So here on this screen, for example, we can look at age and sex structure of people who come to creative health programs and say, well, we've got not many males in this age bracket, so what can we do to target that cohort? And we can also see these primary care networks are our GP practice networks, so who's referring and who's not referring, and so we can go and do a targeted piece of of marketing and comms to certain GP practices, and be able to tell them did you know you only referred 200 people last year to the creative health programs, and what can we do to help you, and etc. So but that's all unlocked by the NHS number. That does mean, though, is a bit what Jayne was talking about, the burden of collecting all that information, is that those creative health partners don't necessarily have to collect all of the detailed information because it's unlocked by the NHS number. So the NHS number will tell you someone's demographics, they'll tell you their postcode, etc. So you don't have to capture that separately. And then it's about how we cut and interpret data, which is really important. So we started overlaying health inequality data into the dashboard. So here the data shows us that the people from the most deprived areas of Gloucestershire are getting support from our creative health programs, which is great. And then it shows us which racially marginalised groups we might want to think about, like what are the barriers then for people from Asian or Asian British communities accessing the creative health programs, and what can we do to reduce the barriers. And then that's another string in our bow of when we go out and talk to different audiences, especially people from the NHS, like when we can overlay this type of health inequality data. And then also the NHS love, the health utilisation data that you collect from an NHS number. So we can look at 3 months or 6 months pre someone coming on to the creative health program, and then we can look at what happens 3 months, 6 months. We actually also do 12 months now post, to show, and we can't say that this is complete attribution. You can't say because they came on this program they stopped going to see their GP, but we can definitely talk about contribution. It contributed to their health utilisation. Actually, what the statistics show is that people tend to use urgent care less and planned care more. And as I said at the beginning, the co-production approach is integral to this, because what we do is we take all this data per program and we take it back to the co-production group. So a bit like what Jayne was saying, we don't have contract monitoring meetings, we have co-production meetings. We're not there to say, you didn't see 20 people last month. We're there to say, this is what the data is telling us. What do we all think? We sense check the data with the people there, and then we ask, what more do we need to know? Do we need more information, or can you add intelligence to this to tell us why this is happening? And then we act to continuously improve. But what we are told in those co-production meetings in the main is that they would agree, the people would agree with lived experience, that they do use urgent care less because they have more confidence in how to manage their health condition. So things like people with respiratory conditions say that they are less likely to use urgent care because they're less likely to get into a full respiratory crisis, because they'll use the techniques that they're taught and they have less anxiety around going into a respiratory crisis. However, what happens at the groups is they all talk to each other, and therefore someone might say, did you hear about this latest thing that you might be able to access? Go and talk to your GP about it. And then that person will go and see their GP. So we do find that planned care goes up. And then the NHS loves a validated outcome measure. So every single program does use a validated outcome measure, but we've all gone through different validated outcome measures. And so, for example, with the respiratory breathe in, sing out, the people who've lived experience told us categorically that WemWebs was awful. So I apologize for people that like WemWebs, and that it wasn't right for them. Now they use something called My Concerns and Wellbeing tool, the MyCore outcome measure, but that was based on the people who've lived experience, their feedback, and they say that's now better for them, and that they get something out of it, rather than WemWebs felt very much like they would tell, this is what they said to me, I'm doing it for you, like so that you can input some data. Whereas I don't know if people are aware of MyCore, but you identify 2 concerns that you want to work on whilst in the programme. And so actually it's a tool that they can use themselves individually and personally as well. And then for children and young people, we found the outcome measures even harder to land on, because we co-produce. We did used to have children in our co-production meetings, but a couple of children came and got triggered by the meetings. And so we actually now have parent and carers come to the co-production meetings, and instead we hold focus groups with the children and young people. And I spoke to the children and young people at one of the focus groups about the outcome measures. And I said to them, like, what do you want to get out of this programme? And we talked a lot about that. And then I said about some of the outcome measures, and they explained they'd spent their lives doing outcome measures, and all they ever did was went down the middle. They were like, we just ticked down the middle. And I was like, well, then you don't get anything out of that. We don't get anything out of that. So a couple of journals have been co-produced with clinicians and also children and young people themselves. And then some of those children allow commissioners and clinicians to see those journals so that we can get a sense of this. And then this is just a bit of a peek and pit around our journey for creating the dashboard. So on that data dashboard, we've got all the demographics, and we can overlay all the health inequality data. We have the health utilisation data, but also for every single validated outcome measure that we use, that is also captured on the data dashboard. So it's all in one place, just to say that. But yeah, I just thought I'd put some of what works well and what was a bit of a challenge for us. And then just to touch on the future, so we really want to combine our stats and stories. So we've given some funding to the University of Gloucestershire, the School of Psychology. They're taking all of the qualitative data from the last 5 years from the Creative Health Consortium partners, and they're turning that into something fantastic for us to showcase, so that the stories are put on a par with the stats, and that we can really showcase to everyone, including the people with lived experience, but also our senior leaders, about the impact of these stories. And actually the stories aren't just individual. I worry that we go and we tell one individual story, but actually there's so much more behind that. And so the University of Gloucestershire are working with us on that. We're developing a new social value framework in Gloucestershire with our hospital and community health partners, as well as our voluntary sector partners, to really ensure that that is a golden thread that runs throughout. And then also we are expanding this and working with colleagues to triangulate information. So for example, there's now a mental health dashboard in Gloucestershire that the NHS use, and we're actually going to be feeding the creative health dashboard to that mental health dashboard, so that not only can the mental health commissioners see how wonderful our creative health programs are and how brilliant they are and they should invest more money in it, but also so that we can start to really triangulate that data. And then we also want to collect data from those furthest from commissioning, because we want people to know that we value their data, whether that's stats, stories, a combination of both. So we actually gave some investment into Create Gloucestershire, who's our local infrastructure organisation for the arts organisations, to really understand how smaller arts organisations capture data, how we can help them to do that for their own sakes and for their own participants, not necessarily just for us, but also to feed into the bigger picture. And so last year we held our first data day where we discussed all of that. Over 100 people attended. It was a really great day. And then we're learning from that to continuously improve on how we help others collect their data.
That was a huge amount of information, and really very rich and super. And Hannah, would we be able to have the slides? I know you suggested we could share them after this session, but yeah. Wanting to build a kind of how to continue this conversation after this session today, and putting it onto Future NHS, where we can share some of the resources and people can then continue to bring the kind of contrasts and comparisons from their own systems, so that we can continue to understand how we could all get data to be more useful at both ends of the spectrum. I'm just going to see if this will work. So I've just added into the chat Hannah's last point there about how do you measure what's not happening within sight of the ICB. Again, this is an illustration we were creating to see if we could understand or decide if it's true that unless the NHS is paying for some activity, that it won't actually see the activity. And so this is an illustration we created in response to that. Happy to debate that further in the breakout rooms later. How's everyone doing? Are we ready for should we do some Q&A to Jayne and Hannah, seeing as we are ahead of time, which I don't think I've ever been on a webinar that's ahead of time. So let's take advantage and do Q&A now. Does anyone have any questions for either Jayne or Hannah so far? Annabelle, do you want to fire away?
Yeah, it's actually not a question, but what I did do in the chat, so you can, to kind of bring to life what Hannah was talking about, during the pandemic, when I was still working for the Creative Health Consortium and Artlift and Artshape, we did a sort of impact of arts on prescription pandemic paper. I've popped it in the chat because what that does is brings to life how we use the dashboard and the qualitative and quantitative work that Hannah was talking about. So please do have a look at that, because that really illustrates the importance of the data and the stories that we gather. So yeah, that was kind of a comment, I suppose, more than a question.
And we have Alex.
Thanks. Hi, Hannah. Obviously, there are quite a few people here from other systems around the country, and even more will see your presentation in the recording. I often think, you know, the history of a place and is so significant in terms of how things develop. And obviously Gloucestershire has got this very long arts and health history. But what would you say to other systems? Because I think hidden in your presentation was the sense that it was really worth pursuing this work because it really does have an impact. And you don't want to sort of generalize about that, I know. But what would you say to other systems? Why is it worth them going on this journey, which is complex and, you know, challenging?
It depends who in the system I was talking to. But funnily enough, I think Bristol have asked me to go and talk to their commissioners, for example, in October. And so I would definitely say to other commissioners, if you really want to tackle health inequalities, if you really want to support the most vulnerable people in your communities, then you really need to invest in this type of activity, in creative health, in communities. And if you really want to know if it works, then you can absolutely capture things like NHS number alongside people's stories to prove to your system that it works. And so I think that, you know, strategically, it absolutely makes sense, but you have to commit to the sustainable funding to be able to capture this type of data. We have a baseline budget for creative health in Gloucestershire, and that means that we can invest in the consortium, we can invest in collecting stats and stories. We're just developing our own creative health strategy in Gloucestershire. We've just embarked on that journey. But ultimately, it comes down to, if you really care about the health and well-being of your population and you really want to capture the people that aren't rocking up to their GP and they're not like, and they're ending up in ED in crisis, then these are the types of things you need to invest in, and you need to put your money where your mouth is.
Thank you.
Have we got any more questions, or any questions about Cornwall? Or Jayne, would you like to describe what where the kind of the fallow grounds and where the rich fertile soil is in Cornwall by comparison to, say, Gloucestershire?
So I guess when I look at Gloucestershire and look at what they're doing, that's really embedded within the NHS, and you've got that total buy-in from the NHS into working that system. So as you said, Hannah, you know, that being able to use that NHS number, that solves a lot of issues in terms of the data that you need to collect and all the rest of it. We are not there in Cornwall in terms of that at all. So we've been doing work, that has been commissioned by health in the past or by public health, but it is not within the health system. So we can only at the moment just imagine how useful that would be. But I know it is about winning over those hearts and minds in terms of this work being important for people to sign it, to buy into it, isn't it, really, to say yes, we're prepared to to have that conversation and to share our data and use our data in that way. And I think we've got a way to go yet with that. It's also, I would say, and it comes back to your diagram, Penny, earlier, where there was a whole bit that we was it the diagram that you've used there, but the bit about where's the work happening that isn't happening as part of a health sector. So where is work happening that has health improvement benefits, but it's not being commissioned by health, and how do we capture that? Because again, your data won't capture that. And that's probably more like the sort of work that goes on in Cornwall, which is much more of a community development sort of approach than necessarily an NHS-led one. So I think that's also something for us to think about.
I know we've got one more coming in from Lelia, but just wanted to double check, Hannah, for the sake of anyone who's got alarm bells ringing in their heads around the NHS number, that the consortium can collect the NHS number, but they can't see people's health records, can they? There we go. Just in case anyone's having a GDPR meltdown with the concern on that. And that's not unusual for Gloucestershire. I know that Bromley by Bow Centre have been doing that in their social prescribing for probably nearly a decade now as well. So it is possible, and you don't have to break people's trust. Okay, so we've got Lelia Grecci. I don't know if I've said your name correctly, but would you like to raise your question?
You did.
And then we're going to go to Brad.
You did say my name correctly. Thank you very much. Thank you ever so much, Hannah. This is so inspiring. I work in Wandsworth in southwest London. And I think the ICB is starting to be ready to be really open to this kind of conversation. And one thing that they seem prepared to discuss the relation to data analysis and impact evaluation and data collection, to start with kind of having a bit of a baseline. So I have two questions for you. The first one is, what kind of level are we thinking about? Because the reason why I'm asking is the council has commissioned a pilot program of 9 creative health commissions, and we've also run an audit of all of that creative health activity which is not commissioned by the ICB and which is outside of the ICB, and to try and embed them within the social prescribing so that the data would enter the NHS data. But what kind of ask is it that I want to go to them with? And the second question is, would you be prepared to come and present your work at the next health and care meeting? That so it's kind of co-produced between the public health services of the local authorities and the ICB, and it was supposed to take place this week, but it was cancelled because of the election. So I'm just wondering if I could get them to squeeze in an extra speaker, since they had already accepted to invite a representative of the Creative Health Programme.
Yeah, I'm more than happy to come.
Okay.
Yeah, I'm more than happy to come. I'll chat to anyone about this.
I was just going to say, if you've got a succinct one sentence to keep us on time, and absolutely catch up after the session as well. But take us to the break, Hannah, with a simple answer, if there is one.
I would say that I'm happy to talk to you in more detail about level of budget, but there's 3 aspects to consider, I would say, which is funding within programs and projects. So make sure that you always add that layer, like, so the project is going to cost X plus 10% for project analysis, evaluation. One of the things we did as well was we invested in a project manager for the consortium who helped all of those organizations with their data. It was AMI. So yeah, which was fundamental in being able to set it up and continue it. We have really good relationships, and we invest in the university as well, the University of Gloucestershire, to be able to help with that evaluation and analysis. And then finally, our own business intelligence team. So in the NHS, we actually have a business intelligence analyst who works with us on creative health on that dashboard. So it's not always about investing money, you know, it's about like making sure that we all invest our time and capacity as well.
Thank you.
Super. Okay, Michael, do you want to give us a brain teaser, and then we're going to have 10 minutes and come back at 2:57.
Okay, so hopefully you can see that now. Just a little bit of fun. So we all love data. Here is some data. I want you, while you go away and have a cup of coffee and stretch your legs, I want you to have a think about what this is. What is this telling us? We were looking at The Lord of the Rings. Now, this might seem a little bit flippant, but it's actually really important to what I'm about to talk about, which is what we are measuring and why, and what story is it that we're trying to tell. So just to give you a bit of background, my name's Michael Cunliffe. I'm the Creative Health Strategic Manager for Northumberland. That's them there. My background is actually as an artist and a creative practitioner. So I worked in arts for mental health for a number of years. And obviously with the creative health report coming out and then the increasing amount of research that followed that, I became quite interested in what the evidence was that we were kind of presenting, which led me to do a bit of research, which is a bit strange because I'm not actually an academic. But we reached the point where the Northumberland County Council and the North East North Cumbria Integrated Care System Board, one of those, approved the setup of a post to look at creative health from a strategic perspective. So they were very, very clear with me that I wasn't there to be operational and kind of set up projects and things, or that will be a part of it. It was about that strategic importance. So with those questions in mind, and I'm very glad to hear that there was a certain amount of skepticism or disappointment around WEMWebs, because WEMWebs was the real bugbear and bane of my life for a number of years. So the project I was working at was a studio for people with mental health issues, and it was a open access model, which meant that once people were referred in, they could keep attending as they felt they had the need. So what you can see here on the left-hand side, we've got this kind of very simplistic model, but it is the model which most of the projects that run follow, and most of the evidence that we have around creative health follows, which is we take people with low well-being or health issues, we do something, and then they have improved well-being. Now, that's where WEMWebs comes in. You do a measurement at the beginning and you do a measurement at the end, and it shows an improvement. And I think what Hannah said really, really sticks with me, which is that if we don't measure what we value what we measure. So I queried this relationship because I didn't feel like it was particularly representative of what was actually happening in our service. So they'd been taking WEMWebs measurements for a number of years. So on the right-hand side, you can see the WEMWebs scores from a number of participants who'd been working with us in the long term. And as I say, we had people who'd been there 20 or 30 years. So we had some people who were really strongly embedded in the use of creative health. And obviously what you see is that their well-being changes. It goes up and down, depending on things that are going on in their life. when you have people with health issues, particularly mental health issues, those peaks and troughs are significant. And if off the top of my head, I believe the score for clinical depression is somewhere around that 30 line. So you can kind of see how people are dipping in and out of that. But obviously, no one is claiming that people who are coming into the service and are seeing reductions in their well-being are being harmed by the art that was taking place. But in the closed model, because this is a closed data model, the people do not exist before we take that first measurement of them, and they do not exist after we take that last measurement of them. And so I was kind of forced to sit down with my director and say, you know, look, if you want to follow the data, we need to kick everyone out every 6 weeks to 6 months, because that's where we get that initial climb. But what they were actually telling us was when they were having their absolute worst times, and in some cases when they were in crisis, working with art was what was keeping them going. It was the thread that was supporting them. So obviously the reason for this is, and Hannah obviously touched on this, I'm sure we've all seen this before. If you haven't, this is the wider determinants of health model. Very, very quickly, there are some things you cannot change. You can't change how old you are. You can't change your sex. You can't change the genetics that you were born with. There are some things that you could change or could be changed for you if you had the power. So things like your employment, your education, the house that you live in. And then there are things that you could change with the right support. So your weight, perhaps your level of physical activity, whether you smoke, how much you drink. All of these things affect an individual's well-being. So, for example, we know that somebody who is retired on a very good pension, living in a nice area, is well educated, is white, is middle or upper class, will have better health than somebody who is living in poverty, in a damp house, is overcrowded and has been unemployed for a number of months and is struggling to make ends meet. What's interesting is that when we look at creative health and its impact, it will impact both of those people. So it will have a positive effect on everyone who's engaged with it pretty much, but that effect is going to be tempered by the other determinants that are going on in their life. And for example, someone who's living, that second example of kind of insecure housing and low income, the chaos in their life is going to cause dips and troughs in their well-being. So my argument was very much, let's not measure well-being. It's not helpful as far as I'm concerned. However, here is a cohort study, and this is a really good study if you've not read it already. A cohort study is when you look at a wide population and say, well, actually, once we screen out things like those factors that we've just talked about, is the benefit still there? Because we know most of the people who will willingly engage in creative activity are the ones who have a range of positive health determinants anyway. But having screened that all out, it would appear, at least according to this study, that there are significant benefits. So lower risk of behavioural instability, reductions in the use of alcohol, tobacco, and marijuana, higher life satisfaction, mental functioning, lower levels of distress, and particularly prevalent to what we're talking about with the NHS, 20% less likely to develop a disability in your 60s if you are creatively active in your 50s. So if you think about the potential knock-on cost of that to the NHS, the benefits of being creative are huge. So if it's not something that just makes you more well, what is it that's actually going on in creative health? And my argument is that creative health is not an activity. It is not something that you give people, but it is a skill. And I have spent many thousands of words, and there is a book floating around somewhere with an explanation of it, to basically explain what practice is to non-artists. So that idea that once you become creative, you have a creative interest and it's becomes self-developing and you pursue your own ideas and there are things that you want to do, was something that had to be explained. So this is the socio-emotional learning effect on well-being. This is a recognized model, and essentially you have these three elements, and you will probably recognize how well most creative health interventions align with this. The opportunities for social interaction and community through socializing, the opportunities for challenge, and the contextualization of success and failure. Now, that's really important because most people live in a world where it's not safe to fail. If you live in a world where your day-to-day activities include trying to make £5 stretch to the end of the week, you cannot afford to fail. There is no safety net. Art provides a space where you can screw up as much as you want without it being something that is damning to you. And lastly, and I think most importantly, is the power of art to be emotionally regulating. So that's something that we see within the flow state. If it's not something you've heard of, do look it up, or I can talk your ear off about it another time, but that will be a whole presentation. But essentially, art provides this rest. And this learning is not something that ever ends. So this is a process that is ongoing for the rest of your life. And that is one of the reasons why artists don't really retire, they die. You know, most artists will make work until they are physically incapable of doing so because it is beneficial and they get joy from it. So when we plug that into the idea of the life course, which is something that's very important in public health, if you think about creative health as a skill, it is something that can be taught at any stage of life. And we know that because we are running creative health programs with all kinds of age demographics. But if you were able to nurture creative health essentially pre-birth, so you've got parents singing to the bump, when the baby's born, they are being creative in a healthy way with that child will be better able to communicate their feelings. As a teenager, they will be better able to regulate themselves and not resort to drugs and alcohol as a way to kind of support how they're feeling. Working age adults, particularly once they hit that midlife crisis, will be more able to maintain a sense of who they are, and again, not fall into drinking a bottle of wine at the end of the day because things just don't seem quite right. And that is going to sustain people in their older age in terms of the continued learning and the protective benefits of that when it comes to dementia. So that is essentially where I'm coming from when I'm working in public health, is that we are not looking at interventions. We are not looking at, we want to do 6 weeks with these people, we want to do 6 weeks with that people. We want everybody, the whole population, to be using creativity to sustain their health. The support that they need to do that will differ based on their health and social determinant needs. So an individual, you know, let's go back to that retiree, very well-to-do, perhaps a bit bored around the house, feeling kind of lonely. If you say, do you know what? Pottery is really good for you. And they say, oh, I've always wanted to try that. They can go and find somewhere to do that. They're not going to face many barriers in engagement. If we are talking about people with, you know, severe mental health issues, or perhaps COPD, people who are isolated, have learning disabilities, perhaps are even inpatients, they are going to need a lot of support in order to engage with creativity. But the goal is to move them from this red, high cost, if I'm honest, intervention threshold through to this green, self-sustaining model. So that's what we want to be doing with people. Now, where does that come into data? It comes into data because when we are looking at that mechanism, not at the how many sessions did you attend, how many bums did we get on seats, how many sessions did we run, what artists did we employ, and we get into the question of, is the population creatively healthy? it starts to look very different. So this is a model that I am proposing as a framework in my area. And it is essentially trying to show how that graded levels of support result in this independent, creatively healthy population. And the importance of this is that from this perspective, the important data is not around the health of the individual. The important data is around how well can that individual access creative health benefits. I have had genuine experience of sitting down across a table from somebody, filling out one of these forms, and they've said, you know what, I've thought about ending my life many times this week. I see no reason why I should be alive. I have no hope. And as an artist, you sit there and you say, oh, have you spoken to your GP about this? And they say yes. There's nothing you can do with that. If instead, as we developed a measure for, they say, I cannot focus on my art at all, I feel overwhelmed, da-di-da-di-da. As an artist, you can say, right, what are you working on? Is it too stressful? Have you tried something new? Let's get up and move around. Let's talk about the things that really inspired you in the first place. It was within creative health to do that. So we have to start thinking about people as people, and creative health not as the answer to everything, but as a part of the answer. So very, very handily, Hannah's already explained most of it, so I don't really need to go into it. But if you think about the data that the NHS is holding as this big old block of health data, they do WebWebs checks. If you're working with people with mental health issues, they're doing them. They're going to their therapist, and they're probably doing them on a weekly basis or a monthly basis. They'll send them out. But they're also measuring things like blood pressure and cholesterol and lung function. And it is in our, in the health model, potentially, those clinicians that are identifying that there are health issues. And we need to recognize that those health issues are unsupported by creativity, which feeds them into our specialty. So what we want to kick out again, once they've gone through our wonderful programs, is that they have improved their ability to use creativity to support their health. That is really what we are doing. So it's an area for development, but within health coding, there are codes to say whether or not someone is creatively active and whether or not they've been referred to a creative activity. Now, trying to get the health people to actually use those codes is an awesome challenge, as Penny will attest, because this is a conversation I believe she's gone around many times. But if we got to a point where a GP would sit down with somebody and say, are you doing anything creative for your health? In the same conversation where they ask how much they're drinking, we would reach a space where all of those health measures, which Hannah was identifying as being attached to the NHS number, could be pulled through, not just for people who've engaged in these programs, but for people who don't. And understanding that and talking to your data quality commissioners and people like that, and understanding that relationship between big statutory data sets and actually what we are doing, I believe can significantly reduce that burden that Jayne was explaining to us of all of these endless levels of evaluation and asks that we are being given. But I think I've managed to just sneak in time. So
thank you so much, Michael. We are, again, Michael, are we able to have either some slides to share, or would you be happy to kind of engage in conversations on future NHS when people bring up certain aspects?
Absolutely, yeah.
Excellent.